please Dr. Urologist, our colleague Kardelis, National Cancer Institute. So please, colleague.
Good day, everybody. Again, I will represent a new raw topic, thematic surgery of prostate for metastatic castration sensitive naive situation. So, prostate cancer is the most common solid tumor seen in men, despite the availability of screening with PSA and digital rectal examination. It remains a significant cause of mortality. Unfortunately, even with significant advances in chemotherapy and androgen axis therapies, overall survival and cancer-specific survival for patients who present with metastatic prostate cancer has not significantly improved over the past 10 years. The mainstay of therapy in this patient has been the use of androgen deprivation therapy with or without use of chemotherapy. More recently, the role of local therapy, such as radical prostatectomy or treatment for prostate radiotherapy local for this kind of patient, it has gained attention. Amount of radical prostatectomies are increased annually, together increased also and lymphodectomies, as I mentioned before, that 10 years before, if you have suspicion of even clinically positive lymph nodes at pelvis, it could be preferable findings for systemic treatment. So it times changes and for better way for operations. According to the operation findings, the risk stage migration during operation is quite high. In high risk group of patients is higher up to 15 patients, and of course year by year the amount of resected lymph nodes are increased also. So better equipment and better skills of operations suggest for better results and higher challenges for more difficult cases. Because the metastasis correlate the amount and survival. If you find in positive lymph nodes, more you find, there could be the overall survival, metastasis-free survival should be shorter for patients. Outcomes: patient treated with clinicals positive lymph nodes improved. So it's not contraindication for radical operation, even more. If you goes to low detectable of clinically positive lymph nodes in pelvis, so you need to reconsider decisions about choosing patients for local treatment. And you take care not in clinical suspectable status of pelvic lymph nodes, but the Gleason score could predict survival of mortality due to prostate cancer. Combined treatment, including with IDT local treatment or local radio treatment, could achieve better survival period. Who is better, local radio treatment therapy or local surgery, radical prostatectomy? It's some science shows that maybe could be for some cases better surgery, but otherwise the possibilities are very individual and general issue that is adequate to each other. And as radical prostatectomy, for example, with lymphadenectomy is becoming more often and more common procedure for locally advanced prostate cancer, as clinically CT3B, T4, N0 or N1. So it's as we have standard above recommendation are strong. So it's only with the additional recommendation that the dissection of lymph nodes of pelvis floor must be extended compared to less risk of patients. So as completely as just for local specific prostate cancer. And what about the additional hormone therapy? Then according to the recommendation of EU is quite weak. You must take strict follow-up patients and show a rising of PCA. And what about more challenging and more fragile group of patients as primary or naive metastatic hormone-sensitive prostate cancers group of patients, which was only care of medical oncologists. Nowadays, we receive more data that in some cases we could be additional part and for local therapy. So let's talk about main part of topic. We will review the most recent and more challenging data, and we will share about experience of our colleagues. So in the 43 patients Stauber and colleagues group, we have been treated locally additional, and compared to with group who refused local treatment, and despite we did not achieve better overall survival or castration-resistant free survival, but we operated patients with prostatectomy. We had less local regional complications. So it's at least they have a better quality of life. Another trial, a long trial, which patients will be taken in good physical conditions with possibility quite long lifetime for local treatment as radical prostatectomy, and another group of patients, which includes 29 patients, we receive as standard just systemic treatment. And the issues was that the prostatectomy showed better overall survival, better response of PCA, and longer time to ADT failure. So, sounds good. Next trial shows as a Carlo Catrini group, strong trials, shows that the patients who receive additionally local therapy, radical prostatectomy or radiotherapy, the median ADT-free survival was 13 months. And for 21 months for MGT group. Of course, it's experimental worker field, but anyway, is quite good result. So, as compare as a multimodal treatment way, that the oral studies is the local treatment, but not directly of as a primal tumour or metastatic directed therapy may be safe and delay disease progression. This is as mostly of radiotherapist results. Therefore, a significant selection bias affects reliability of the data, the currently reliable, the lack of direct comparison among all mutated therapeutic strategies for metastatic hormone-sensitive prostate cancer represent a challenge for scientists and clinicians. So, the most parties choose the right treatment for right patient. You need to discuss all time with multimodal team, MDT, to choose and to prescribe the best treatment option for patients.
Thank you for the presentation. We have one question from the virtual audience. Is surgical castration associated with better non-oncological outcomes? Is surgical castration associated with better non-oncological outcomes?
Surgical castration is as for metastatic prostate cancer is patients don't receive local treatment only. They receive a multimodal treatment. So only medical castration for this patient, of course, this is a group of fragile patients. I mean that primarily we have spread disease patients, spread oncological disease patients. So it's you need, if you see that the local treatment could be benefit or field of benefits, then you can try to choose local. As standard treatment, anyway, remain systemical treatment. So this is an androgen deprivation treatment. You can't avoid it. So it's according recommendations. On standard recommendations, you need to include immediately it. So yes.
Thank you very much.